As we get closer to your surgery date, there are a few logistical reminders that I want to make sure you're aware of that are important for our coordination to make sure that we have a smooth surgery day. Additionally, around this time, I find patients usually start getting nervous about how much pain they're going to have immediately after the surgery, because now that it's getting closer, you're thinking more about the short term rather than the long term of your eventual recovery. And so I think today serves as a good opportunity to go over my pain control regimen as well, so that you know what we're going to do to try and keep you comfortable around the time of surgery. One of the biggest aspects of coordinating everybody that's involved in your care as we get ready for your surgery is the various visits and check-ins that you have. This will involve your primary care provider, the anesthesia department, usually a nurse from the anesthesia department, and then someone from our team, usually a physician assistant. What we're trying to do is make sure that we're looking at your health and your planned surgery from every angle we can possibly think of, so that we've done all of the planning beforehand, and on the day of surgery, we're just executing the plan that we've come up with previously. This can involve a lot of work on your part to run around all these various visits, but it's an essential component of making sure that we've gotten everything we possibly can in order for you before the day of your surgery. There are a few certain medications that will need you to stop at a pre-specified time point before your surgery. If you're taking any of the medications that are shown on the list here, this includes the timing of when you'll need to stop those. It's important that you follow these instructions so that those medications don't interfere with your care around the time of surgery. It's usually around this time that people start getting a little bit worried and a little bit anxious about the pain they're going to have from the surgery itself. You're used to the pain from your arthritis, but you don't know what the surgery pain will feel like. This is normal. Of course you would be anxious about this. That's totally understandable. I want you to know that I'm going to do everything I possibly can to keep you comfortable. I will leave no stone unturned in minimizing your pain. With that being said, we have to also accept that there will be some discomfort. We want it to be as little as possible, but we also go in with the expectation that there will be a short-term pain, and that's okay. That's what we're going through in order to get to a better place, and this is all just part of the process. And one of the best videos I've ever seen at explaining this comes from a surgeon out of the Netherlands who walks through how to conceptualize the concept of pain. And honestly, I bet you're probably already getting sick of listening to me talk, so I just put his video straight in here next, and hopefully that will help you understand how I want you to think about pain in the early post-operative period as you and I walk through this process together.
We'd like you to be as comfortable as possible as you recover from injury or surgery. It may be difficult to believe, but the single best thing you can do to get comfortable is to remember that injury and surgery hurt. Your body needs time to heal. If you forget this, it may feel like something's wrong. Pain is much worse when it feels like something's off. To understand this, it's important to recognize the difference between nociception and pain. Nociception is the physiology of actual or potential tissue damage. Pain is the cognitive, emotional, and behavioral response to nociception. Soccer players can pretend they're hurt, while hockey players pretend they're not. Some have substantial nociception and little pain. Others have substantial pain without detectable nociception. In the United States, if you break your ankle and have surgery, you take one of the strongest oral opioid pain relievers available. In the Netherlands, you take acetaminophen, a non-opioid pain reliever, just as in most other countries. And pain intensity and satisfaction with pain relief are no different. It seems that when a Dutch person breaks their ankle and has surgery to repair it, they think, this is going to hurt. But in the United States, we think, why am I hurting? In the United States, people who take more opioid pain relievers after fracture or orthopedic surgery have more pain. So what's a better strategy? Remember that pain is part of the healing process. Give your body time. Get into your normal routine as soon as possible. Do the things you love. Get absorbed in them. Take as few opioids as possible. Try to use them for sleep and only for a few days. As you get better, cut them in half or in quarters. You can get a pill cutter at the pharmacy to make this easier. Make sure you discard any leftover pills in a locked disposal unit. You can find one in many hospitals and police stations. The human mind is a great storyteller. When the story your mind is telling you is making things worse, say, "Thank you, mind, for that story. But I did just have surgery." Meditate. Focus on your breathing. Watch something funny and do it with friends. Distract yourself.
While there will be some degree of discomfort following your total hip, our goal is to keep it to a manageable level. I can't eliminate all of the pain from the surgery that I've performed, but I want to keep it to a minimum as much as possible so that you're comfortable enough as you recover. The first thing that I do starts during the surgery itself, and this involves an injection that I put into various structures around your hip. We know which structures in the hip have the highest density of nerves, and so I put local anesthetic into those areas so that I'm trying to stop the pain at the area where it's going to be felt. Additionally, there's a nerve that I can access during the surgery, so I put some local anesthetic near the nerve itself as well. This tries to block the signal as it's conducted up to your spinal cord and from there to your brain. Additionally, there has been a lot of studies on what should be in those injections. And the one that I based my practice on was a randomized controlled trial that looked at comparisons of various medications and found that a combination of 4 medications actually provided a combination effect that was greater than when they were used in isolation. And so that's exactly what I use. I use not 1, not 2, not 3, but 4 different medications in the injection, all of which are aimed at controlling your pain. While we're numbing you up inside your joint with the local anesthetics, I also want to numb you up on the outside of your joint with ice. And this is why I place such a big emphasis on those ice machines. I really think that they not only are more effective than ice packs, but I think they get used more often as well because it's more convenient. And so I want you to bring this with you to the hospital so that right when you wake up, we've got 2 different ways we're trying to numb up that joint. And I think that if we can get you comfortable right away, it lowers your anxiety about what your pain control is going to be like moving forward. And there are actually studies that show that if you're less anxious, you will experience less pain. So if we can make you comfortable right away, then that comfort is going to carry forward from there. We also talked about meditation and mindfulness last time, and this actually works. This has been studied scientifically and has a pain control effect that is just as robust as a lot of the medications we use. So again, if you're looking for ways to control your pain, this is a very effective one, and here are some of the resources that you can use to engage in that. The last component of your pain control regimen is medicines. I think it's really important to point out that we've been talking for quite a while about how to control your pain, and I'm only now getting into actual pills. The reason is that in this country, we tend to think about pain as something that needs a pill to eradicate it, when in reality, it's a much more complex experience than that, as was touched on by that surgeon from the Netherlands who I showed in the video earlier. Now, I think it's essential to be using what's called a multimodal pain regimen, where there are multiple different modalities of pharmaceuticals that are being directed against your pain. By far the most important one is anti-inflammatories, or NSAIDs. Some patients can't take this if you have particularly bad stomach or kidney issues. However, if at all possible, I want you to be on them. Usually I use meloxicam, But if you have one that you find works best for you, I'm fine with you being on that. But I want you taking anti-inflammatories no matter what, unless there's a compelling reason from a medical perspective that you can't. Additionally, Tylenol provides very good pain relief, and I want you taking that too. In some cases, I'll use nerve medications such as gabapentin or Lyrica. However, there are some side effects associated with these, and typically I don't employ them. But if you're having pain that seems to come from a nerve, then I would employ those in addition to the Tylenol and the NSAIDs for you. Finally, there are opioids. I do prescribe opioids after my surgeries, and I want you to take as few of them as possible. If I could, I would avoid my patients taking them at all. However, I realize that in the early time frame following surgery, this may help you to get comfortable enough that you can fall asleep. But there are huge downsides to taking opioids, and it's one of the main reasons I'm so careful about doing everything I possibly can to use everything else for pain control. Number one, as we're all familiar with from the opioid epidemic that's raging in our country, these are very similar to street drugs. The opioid that I use most often is oxycodone, and you can see here the chemical structure of oxycodone relative to heroin. They're very, very similar, and I take this very seriously. They have a real addictive potential, and if you're taking them long term following my surgery, the likelihood that you're going to get off of them goes down and down and down. So, in order to keep you from getting addicted to them, I want you taking them for as short a period as possible. Now, it's not just the addictiveness that I worry about with opioids. It's also the side effects that occur from taking them, whether or not you ever develop an addiction. And to underscore how big a market there is for opioids in this country and how bad the side effects are, I'm showing here a commercial that ran during the Super Bowl. And that commercial was just for dealing with the constipation that's caused by opioids. There is a pharmaceutical company out there that spent millions of dollars to advertise that they could help patients poop while they were taking opioids. This tells you how big a market there is for opioids in our country, and also how severe the side effects are for your GI system. If you want to be able to poop following your surgery, don't take opioids. Finally, the goal of taking an opioid for a patient is to decrease your pain. However, there's good evidence that taking opioids actually makes you more sensitive to pain. So while you may get some short-term relief, you may be paying the price for it in the long term in pain, the exact reason you're taking the medication in the first place. These reasons, among others, including lightheadedness and nausea and fatigue, are the reasons why I want you to take as few as possible. These are really, really dangerous medications, and I understand that they may be necessary for you for a very short period of time, but I want to limit that as much as we possibly can because it's the best thing for your health. My goal in making this video series is to supply you with all of the essential information you need to know what's coming your way as you work through the process of a joint replacement. The portion that's about to follow is not essential. I'm going to go through what I use to accomplish a joint replacement, how I go about doing it, and why I do it that way. If you don't want to know the what, why, and how of a joint replacement, then feel free to close out at this point. However, if you're interested in some of the details about this, then I'm going to share those here, and we can talk about some of the various options that I have and how I employ them for different patients. There are multiple different approaches to the hip, and there are surgeons out there who can achieve good results with all of them. Personally, I use the anterior approach to the hip in almost every hip replacement that I perform. I'm a very strong believer in this, and the literature has shown a few clear benefits for it over other approaches. The first is in the early postoperative recovery. It is a little bit faster with the anterior approach than with alternative approaches. However, I don't actually think that this is a compelling enough reason to choose to use that approach. I'm much more interested in your long-term outcome than your short-term outcome. And while it's very nice to be able to have patients recover a little bit quicker, I'm much more focused on how this is going to do years and years down the road. And that's why I choose to use the anterior approach, is because of the decreased risk of your hip dislocating long-term. There are multiple reasons why the anterior approach leads to this, but it's quite clear from the literature that the lowest dislocation risk comes when the surgery is performed through an anterior approach, and that is the reason why I use it. This animation shows what a total hip actually looks like. During a total hip, we have a femoral stem with a ceramic head on the end of it, and an acetabular cup with a plastic liner inside of it. We cut off the portion of your hip that has arthritis and insert the metal stem down the canal in the femur. Then we put an acetabular cup in on the socket side and put the plastic liner inside of that. Then the ceramic head rubs inside of the plastic liner, and that forms your new artificial hip joint. This cartoon shows what it looks like after it's been implanted. You can see there the femoral stem going down the femoral canal and the acetabular cup, which is on the socket side. In this case, both of these have ingrowth surfaces where the bone actually bonds to the metal, and that's what provides the long-term stability. Here's what that implant bone interface looks like at a microscopic level, which comes from an analysis of the DePuy actus, which is the uncemented hip stem that I use. Here you can see the bone actually growing into the pores in the titanium, which are about the same size as the pores in the bone. This creates a very rigid bond that allows the hip stem and the surrounding bone to move as a single unit and be rigidly joined together. If you have poor bone quality, also known as osteoporosis, I won't rely on your bone to grow into the stem, however. Instead, I'll fill up the canal with cement. And you can see here a comparison of what those two look like relative to one another, with the one on the left being an uncemented stem and the one on the right being a cemented stem. The reason why I do this is that in patients with poor bone quality, using the cement decreases your risk of having a fracture around your hip stem.